Thank you.
Thanks.
And now we'll invite Dr. Mudit. He is speaking in place of Dr. Rajiv Reddy, and his topic is endoscopic vitrectomy for endophthalmitis.
All right, so good evening, and once again, thanks to the scientific committee for allowing us to talk on this. So I have already spoken in the last session on how endoscopy can help us in a lot of our different scenarios and how it can help us in obviating the problems that are caused by media like this, which will not usually allow us to visualize what's happening inside the eye. And endoscopy, because of the virtue of the fact that you are able to go inside the eye with an optical source and a camera, helps us in obviating or taking care of eyes where there is no good view of the anterior chamber, either because of corneal opacities or exudates. It also, like I said, helps us in getting away without using a temporary keratoprosthesis in a lot of these cases. We have already discussed about the endoscopy system and what it is. But what I'll show is that we also then subsequently assessed our experience of endoscopy in 33 eyes and how it helped us. The main point is that endoscopy allows us a window of much earlier intervention. Just in the previous talk, Dr. Ashish Lal was talking about how they were able to salvage the eye and get good visual outcomes because they were able to inject in time. The same way, if we are able to intervene in time and do a much more thorough cleaning of these vitreous opacities, taking care of these exudates as early as possible, it does allow us for a better outcome. So what we found was that cases which were managed relatively early in spite of poor visualization, the evisceration rates in some of the eyes had dropped, was just 3.03%, or just one eye had to subsequently undergo evisceration. Otherwise, which could have had a much worse outcome if we had not done an endoscopic vitrectomy in time. So this was one of the cases. This is actually a video of Dr. Rajiv Reddy's case where there were these dense exudates, and what you can see is that with the help of an endoscopic visualization, we were able to clear up most of these exudates, take care of all of these peripheral vitreous exudation, and also, while we can obviously take a biopsy and give IOAB, but clearing up of all of these vitreous exudates allows us a much better intervention. So now you can see that most of this retina is absolutely healthy. We are able to visualize the entire disc and the retinal structure, and all of these exudates have been taken care of subsequently. These eyes, once they improve, we can also plan for subsequent corneal interventions once the media is clear. But you can see how nicely all of these exudates have been removed, and we can visualize an underlying healthy retina. So endoscopy gives us that opportunity. This was another case where there were dense exudates, and what we can see subsequently over here in this video is that the video is moving. There, here. Is that we are able to again go inside, take care of these peripheral membranes, and it gives us an opportunity to take care of all of these exudates without causing much of a damage to the eye. It allows us a better visualization, which we could earlier not have done because of the corneal opacities, and allows for a much better intervention and much better outcomes in a lot of these cases. So this was one more case. This was a patient who had got a trauma and an intraocular foreign body along with endophthalmitis, was managed by my colleague Dr. Vivek Dave, and this is how the eye was subsequently after a month. So this is at 6 weeks. They were able to get a good visual acuity of 618 in this eye, and were able to take care of the foreign body removal as well as taking care of the endophthalmitis. So in a nutshell, endoscopy allows us for a much earlier intervention in eyes which have got an opaque media, also helps in removing these foreign bodies, and allows us an opportunity to take care of our patients at a much earlier time than what we could have done if we were waiting for the media to clear. Thank you so much.
Excellent presentation, Dr. Mudit. For the youngsters who would like to understand more about endoscopic vitrectomy, would you just explain how a person who is about to learn endoscopic, how does he manage about the dimensions of the endoscope so that he doesn't see upside down?
So that is pretty simple. Like we had shown in our earlier talk also, the initial part is getting used to the endoscope and getting an orientation done. Before you enter the eye, it becomes important for you to look at, because you are not visualizing heads on, we are visualizing end on. So you are seeing the screen and see what's there in front. So before you enter the eye, it becomes important for us to orient our endoscope so that what we are visualizing is absolutely the same as what we see on the screen. So before you ensure that you focus on anything, either you want to focus on your cornea or a forceps, forceps and ensure that your visualization is absolutely same as what you're seeing in front of the screen. And then you enter. The other important tip is to always ensure that, because you've got a very limited view, to ensure that your instrumentation is in the visualization of your camera. That is the most important point. So you have to constantly be in a habit of visualizing your forceps or your instrument, and your camera should be focusing upon that. So you move both of them together. Normally we have a light pipe here, we are able to visualize what's happening all over. But over here, you have to move your camera and your light source along with your instrument, so that constantly you're focused on the area where you are working upon.
Because of these issues, now Vistec has come up with a camera and a light pipe, which, like how we have a knob on the top of the Alcon constellation.
Yeah.
So they have come up with a endoscopic vitrectomy where there is a knob, which helps us to, we don't need to like hold a sticker and see whether it is upright or not.
Exactly.
So that's quite kind of a good change they have done.
Yeah.
Thank you.
Thank you so much.
Okay. Yeah.
So now, in these cases again, so if you have got a media which has subsequently cleared up a little bit, you can still visualize. If not, there are other clues to, if it's a case of endophthalmitis, there are multiple clinical clues which can also tell you how your patient is improving. Your cornea starts getting clearer, your AC exudates become reduced or are regressing. Once you're able to sometimes visualize the iris details and the details, the exudates start getting regressed. Those again are clinical clues. Apart from that, you will have to rely on an ultrasound B scan subsequently to follow up the exudates are regressing or not.
Can I press upon a very important
Thank you so much.
observation here? Like how in the last few years, Dr. Haripreet Arvind, Dr. Chang have come up with intracameral moxifloxacin for cataract surgery. Endophthalmitis after vitrectomy is a known phenomenon. So do we, Dr. Das, the entire panel, do we think the vitrectomy surgeon should end up injecting moxifloxacin in the entry chamber before FX or just after FX with a 30 gauge needle? Do you feel it is necessary, because that has been lately being discussed? Intracameral injection of moxifloxacin has been talked upon. Is there any at the end of the vitrectomy surgery? Is there a role of that in preventing
Vitrectomy?
Yes.
See, the thing is, you need to understand the mechanism between cataract surgery and retinal surgery, vitreous surgery. Vitreous surgery is an egress system. It actively pushes out everything. So, not many cases require an intravitreal antibiotic at the end of vitrectomy. Very less likely that endophthalmitis will come, and these cases you need to be very observant in the post-operative period, because endophthalmitis in cataract surgery can present very early, whereas in post-vitrectomy these cases to present also it will take a lot of time, and if endophthalmitis is developing post-vitrectomy, it is much more dangerous because residual vitreous only it can show up. So treatment also much different when it happens in cataract surgery than in vitreous surgery. As a routine, we don't advocate any antibiotic for vitrectomy. Yeah. Ashish Lal, wait. Ashish Lal, you want to answer? Yeah.
Actually remove the entire medium in vitrectomy, just the peripheral skirt is there. So there is no medium for the organism to grow. So in case of these patients, if we have endoff, it's going to be very severe. It means we've actually inoculated too much in it.
Yes.
And besides, moxifloxacin as sir has shown that it's like only 30 to 40% of the bacteria are going to be, sensitive towards moxifloxacin. So probably the role of Vigamox may be questionable once the
That's true.
comes out.
Yeah. Thank you, Kajal. You want to ask some? That's what I said. No, for after vitrectomy, it is not indicated. Let us not do it, because the percentage of occurrence of post-vitrectomy endophthalmitis is very less, and it is a egress system which we were working on compared to a ingress in case of cataract surgery. Okay, with this, I hope, is Dr. Rajiv Jain is there? If he is not there, we came to the end of this fifth session and end of the day of Retina Specialty Day. It is a dedicated Retina Specialty Day from morning 8:30 to now 5:30. It's a continuous except for 1 hour. We had a cataract surgery session by Uday Devgan. And I thank all the panel who participated here, and mainly this guy from AIOC Scientific Committee, Piyush. I used to scold him, but I appreciate him. Since morning, he's there along with me for this day's session. And I thank all the delegates for your active participation, and really it's made a difference